Hi friends. On DAMS Daily YouTube channel, we have initiated a series called as Unplugged, where we have dealt with a lot of clinical and a lab correlation and clinical pathology correlation, clinical microbiology correlation in the past. And I'm sure, if you have not seen them so far, please scroll through the playlist provided in the YouTube, where we have discussed a lot of medical cases. And today, when I was doing my own reporting today, I saw a very interesting case. And I thought it is worthy of unplugged. It's a very, very interesting case. I called Dr. Poonam here. She's a leading biochemistry faculty, and we'll talk together and we'll find out, what we're looking at. I'm sure you might have guessed already that we're going to look at something which has a biochemical
Biochemical
angle
aspect to
aspect
it,
to
yeah.
it. So this is a patient who was a baby girl born out of consanguineous parents, and she was born at term with an uneventful pregnancy, normal vaginal delivery. Fifth postnatal day, she started developing poor feeding, lethargy, seizures, and on 11th day she developed hypotonia and poor neonatal reflexes. Now you can already see the history. And when you see such a history, the consanguineous parents, we are already looking at something to do with some inborn error,
Metabolic cause,
metabolism,
yeah.
or a metabolic cause. And you can see a deterioration happening from 5th to
Yeah.
11th day. And whenever we see such a thing, we have already trying to look at the pregnancy profile. Was she preterm or any event at the birth? And there was no such event at the birth. It was a
Yeah, the
normal
baby
vaginal
was
delivery.
almost normal at the time of birth, but there was progressive deterioration, what I can see with this history. Fifth day, she was having poor feeding and lethargy, but by 11th day, all the neurological manifestations started appearing. So it's a progressive disorder where the baby was almost normal at the birth.
Yeah. So, as a routine, you would always look at the routine biochemical, especially the electrolytes, before we start thinking of anything. And we saw the electrolytes in these patients were within normal limits.
That's all. Yeah.
So, and this is where the radiology comes into place. An MRI of the brain was advised, and which we are looking at right now. The MRI sequence that you're looking at right now is a diffusion weighted MRI. This diffusion weighted MRI can show you the cytotoxic edema or the intramyelin edema that we can see in this patient. So when you look at this patient on MR, you can see there is abnormal signal in the pons, in the midbrain, in the thalamus, in the area of the basal ganglia, in the area of the posterior limb of the internal capsule, as well as in the centrum semiovale part. So this is the area where you have the myelination in a newborn. So in the areas where you have myelination, we are able to see cytotoxic edema. And this is very typical of a disease which I'm gradually going to unfold for you. But let me show you the findings again. So we saw the abnormal signal in the perirolandic area, in the posterior limb of the internal capsule, in the pons, in the cerebellum, and we are seeing edema in the myelin, to put it in layman's term, or we can say cytotoxic edema on a diffusion weighted MRI in places where you have myelin. And when we do a MR spectroscopy,
So you mean to
M
say that in this kind of finding, you can always assess that particular patient is having problem in the myelination,
Yes, and
and
we saw that when we did a MR spectroscopy,
yeah,
where non-invasively using MRI technique, today we are able to look at the biochemical metabolites. So in addition to the classic peaks that you see in MR spectroscopy of choline, creatine, and acetyl aspartate, you can see two extra peaks here. So one you can see at 1.3 ppm, which is the lactate peak. And at zero point 0.9, you can see a peak, which is where the branched chain keto acids are there, which are elevated in this patient. And we can see a smaller peak at 3.6, which is where you have the valine. So we have now a suspicion of we are looking at some abnormality with the branch
yeah,
chain
branch in because valine is
amino
there and
acids.
keto acids are
Yes,
there. So
yes,
certainly it
and
is
please lactate
hypos.
is also
Yeah,
available.
lactate is also
So
high.
now
So
when I put together the radiological
yeah,
findings,
yeah,
we can see intramyelin edema, which is
associated with increased
with a
level of
disease
all these
which is very classic of a disease called as maple syrup urine
maple
disease.
syrup urine disease.
And
Yeah.
the edema that we see here is often we in radiology we call it as a myelin splitting edema,
Okay.
which is because of accumulation of the water
Water
and these
in
amino
that.
acids
Okay.
between the
Yeah.
myelin chains, leading to such appearance.
Yes.
And key to understand is that the edema was seen in this patient in the areas where you normally have
Have the
myelination.
myelin. Yeah.
So it is not that myelinated area is looking abnormal on
Yeah.
diffusion weighted MRI.
Yeah.
So this is what my diagnosis is. But however, the discussion will not be over till the time we look at the biochemical aspect.
Biochemical
So I'll
aspect
ask
of
Dr.
it.
Poonam that how would you go about confirming this patient? How would you go about confirming what exactly is this disease all about? So that
Yeah,
because as a radiologist we know this much, but
yeah.
what is happening
No, but
inside?
I feel that MR spectroscopy, what finding you are having, that particular graph, which is showing you the increased lactate, ketoacids, and valine. It's a very classical finding, hinting towards the diagnosis of Mabel syrup urine disease. And it's not a very common disorder. It's an inborn error of metabolism, which is autosomal recessive. But when you talk about the incidence of this particular disorder, it's quite rare disease, and 1 in 1 lakh, 85,000 babies are unfortunately having this problem. And let me explain about the biochemical aspect of it. What is this disease? What enzyme is actually deficient? This disease is actually the catabolic disorder of branch chain amino acids. As we all know, we have 3 branch chain amino acids. I always ask my student to put it on in order of LVI, because leucine is something has got very playing very very important role in occurrence of this disease.
Okay.
So we have 3 branch chain amino acid: leucine, valine, and isoleucine, and they follow the common route, at least initially during their catabolism. And this slide, I feel, will be very helpful to understand the initial aspect of catabolism of branch chain amino acid. There you can see the first enzyme is the transaminase enzyme, which is like transaminating these 3 amino acids, like many other amino acids are undergoing transamination. There, the problem is not there in this disease. The problem is there at the next level when we are talking about the keto acid oxidative decarboxylation catalyzed by this particular enzyme. This enzyme is deficient in this MSUD patient. And
Keto acid
this,
dehydrogenase.
yeah,
Okay.
it is alpha keto acid dehydrogenase complex. It's
Okay.
actually a complex enzyme. Complex in the sense it is having 3 enzyme in it. So it is called the enzyme complex. So this complex is deficient. So because of that, the keto acid degradation is badly affected.
So that
And
is why they are accumulating.
yeah, all
Okay.
these 3 keto acids
Okay.
are not undergoing oxidative decarboxylation, so they tend to accumulate. And leucine is afflicted maximally
Okay.
because the deficiency of this particular enzyme complex enzymes is having the main effect on leucine catabolism. And moreover, the keto acid of the leucine amino acid is very dangerous. If we see the pathophysiology, it is the keto acid of leucine, which actually is creating all sorts of problem in the brain. So basically, I just wanted to highlight here, okay, it's like branch in amino acid, catabolic defect, and the enzyme complex which is deficient is branch in alpha keto acid dehydrogenase enzyme complex.
Okay.
And as I told you, this enzyme is complex, having 3 enzymes. Another complexity is that each enzyme is trifunctional in this enzyme complex. Trifunctional means for all the 3 keto acid, we have got E1. For all the 3 keto acids, we have got E2. And then for all the 3 keto acids, we have got E3. So one enzyme complex deficiency will result in accumulation of all the 3 keto acids. And this next slide is talking to you about the approach to patients suspected of having the uh, maple syrup urine disease. This maple syrup urine disease assessment should be done as a part of neonatal screening program because the diagnosis need to be done very early. When you delay the diagnosis and you delay the treatment, the start of the treatment, there is progressive deterioration of the patient. So the diagnosis should be done pretty early. So it's a part and parcel of neonatal screening program, newborn screening program. And what is being done is the assessment of plasma level of leucine, valine, and isoleucine. Normally, these amino acids are not very high in the plasma, but in such babies, by a few days of life, you start finding very high level of leucine, valine, and isoleucine amino acids and their respective keto acids also, because they are not catabolized properly due to lack of enzyme complex. And one important finding is the presence of allo-isoleucine. This allo-isoleucine, this is though there in the plasma, but it is there in a very small amount. It's an isomer of isoleucine. Now, in this baby, when the isoleucine catabolism is defective, the isoleucine tend to get isomerized to form your allo-isoleucine. So this is one unusual finding,
Okay.
which is hinting you towards the derangement in the isoleucine
Catabolism of
catabolism.
the
Yeah.
MS.
So that level is going to increase. It's going to be more than 5 micromole per liter. Otherwise, in a normal healthy baby, if you see the level is less than 5, at times you find negligible amount in the plasma. So this is a very classical finding which can be seen. And this test, DNPH test, this is a very simple test. You just need to use dinitrophenylhydrazine reagent, and in that you just have to take equal volume of DNPH reagent and equal volume of the patient's urine. You have to mix these two together, and after 10 minutes, if you're getting in the test tube the yellow white precipitate, curdy yellow white precipitate, that's a diagnostic of presence of maple syrup urine disease, because this DNPH interacts with the keto acids which are actually accumulated during lack of the steps beyond that. So those keto acids, they interact with this DNPH to give you yellow white precipitate. So that's one very very much diagnostic finding in case of maple syrup urine disease. So this is the approach to a patient when the patient is coming with the history that patient is born normally and progressive deterioration. And if you the case which you presented is also showing you very early deterioration. By fifth day, by seventh day, the baby is deteriorating. So I can explain this slide where this is explaining exactly why there is so much of neurological deterioration when the baby is having a lot of leucine, a lot of other branched amino acids and their corresponding keto acids. See, out of all the three amino acids, most notorious amino acid in this, which is said
Leucine.
to be involved, is the leucine. Because that troubles the brain maximally compared to the isoleucine and valine. And that is why when the treatment is given, leucine is completely restricted, and isoleucine and valine can be given in a tapered dose.
Okay.
So leucine, what actually leucine is going to do? Leucine is entering the brain. You can see the blood-brain barrier, and this is the blood, and this is the brain. Now, leucine is high in the plasma, in the blood. Now, leucine will enter the brain using a transporter. This is called large amino acid transporter number 1.
Okay.
So, this particular transporter is transporting large-sized amino acid in the brain. It is there at the blood-brain barrier. Leucine is also considered as a large amino acid, and the irony is this leucine is having very high affinity to this LT81.
Okay.
Very high affinity, very low Km value, very high affinity. So it tends to bind this transporter with high affinity, and it enters the brain. And in that process, what happens, if you can see the small amino acids, the small alphabets you can see over here, these amino acids, they are not getting opportunity to cross the blood-brain barrier through this LATS, because all leucine has having strong affinity to this transporter. So it is like competing with all other amino acids to enter the brain. So leucine enters predominantly. All other amino acids to name, you can see tyrosine, phenylalanine. There are so many amino acids: tyrosine, phenylalanine, tryptophan, histidine, isoleucine, methionine. Nothing is entering in the brain. Now that creates a problem. If you see, now leucine has entered. Now other amino acids are not entering. And as we all know that these amino acids are very, very important to produce you catecholamines, serotonins, which are neurotransmitter, melatonin, which is a hormone. Tryptophan is involved in serotonin, melatonin production, histamine production. When we talk about tyrosine, it is involved in catecholamine productions, dopamine production. So all those things are not getting properly produced in the brain cell because the respective amino acids are not reaching in the brain cell. So that results in neurological deterioration. The baby is having neurological deterioration. And this is not the only thing which is actually seen in this baby. This particular thing is the respective keto acid of the leucine. After action of transaminase, we get to have alpha keto iso caproic acid. This is the respective keto acid of leucine. Transaminase is acting normally, so this keto acid is formed. Now this is not further metabolized. So in the plasma of the baby, this is going to be high in amount along with other keto acids which are coming from isoleucine and valine. But they are not that troublesome. This is very troublesome because this is entering the brain using monocarboxylate transporter. It is monocarboxylate acid. So it is using this monocarboxylate transporter and entering the brain. Now what it is going to do inside the brain? The next aspect is very, very important. When this keto acid is entering the brain, you can see in the next aspect, it is undergoing transamination. See, the keto acids, they have tendency to absorb the amino group. Now, this uh, alpha keto isocaproic acid will start accepting the amino group from glutamate, and it will get converted to leucine again. So, in that process, brain will have deficiency of glutamate. When glutamate is not there, glutamine is not there. When glutamate is not there, GABA is also not there. Glutamate is a very important excitatory neurotransmitter, and GABA is a very important inhibitory neurotransmitter. Now we have lack of everything in the brain. So that's an important reason of neurological deterioration in this baby. Baby is irritable, baby is lethargic. So all those features are because of derangement of these neurotransmitters. That's because the glutamate is gone to transfer the amino group to this keto acid in an attempt to convert it to leucine. So that's another problem which we find in this baby. So
And I can also see the lactate here. So
yeah,
I was just wondering that,
yeah,
like,
lactate.
we saw the lactate on our
Yeah, it is
spectroscopy
a
as well.
very
So why
important
is the lactate
observation. Yeah, it's a
accumulating?
very important observation. I know you're a radiologist. You can see even the hidden lactate over here.
Well, we
So
saw that on
I,
spectroscopy
yeah,
as well.
yeah. So lactate also is very high. The reason for this particular conversion of pyruvate to lactate, I'll explain you. It's very interesting if you go into the biochemistry of it. Basically, the metabolites which are reaching the brain and which are forming you other things, they have especially this keto acid which is going, it is doing this problem, but in addition to that, by unknown mechanism, it is inhibiting electron transport chain.
Okay.
The oxidative phosphorylation is inhibited. You can see over here. This is also inhibited by this particular keto acid. Now, when ETC is blocked, you'll have high level of NADH, you'll have low level of low level of ATP, high level of NADH, low level of ATP. Now, this is the fertile media. When the NADH is high and ATP is low, it's a fertile media where pyruvate will be converted to lactate.
Okay. So that
We
is why we
learned the
saw the
anaerobic glycolysis if you
yeah.
have some
So
idea of
yeah.
it. Whenever
So
NADH is high,
yeah.
you have conversion of pyruvate to lactate. Now, ETC is blocked, so NADH is piling up. That is converting the pyruvate to lactate. So, lactate accumulation is also there in the brain.
Now, I'll request Dr. Poonam to, highlight a little bit about the types of the disease. Like,
Yeah.
what are the, as a biochemistry,
Yeah.
person, can
As
you
I
help
told
us with
you,
the
there are three
types?
enzymes in the
Okay.
complex, right? So now, depending which particular enzyme is having the mutated gene, whether it is first enzyme or the second enzyme, we have got subtypes of maple syrup urine disease. Incidentally, third enzyme deficiency is very rare.
Okay.
Third enzyme gene mutation is very rare. It's mainly the first and second enzyme of this enzyme complex, which is actually having the mutated gene. Now, if you go in a little detail of the names of these enzymes, the first enzyme is actually branch chain alpha keto acid decarboxylase enzyme. That is having two subunit. The first enzyme is having two subunit.
Okay.
If the first
1A and
subunit
1B.
is mutated,
Okay.
it will have MSUD type 1A.
1A.
If the second subunit of E1 is mutated, you'll have MSUD type 1B.
I think
And
that's in the name
yeah,
as well. I think
this is the name of the
A and
gene
B, and I
actually.
think
This is branch chain keto acid dehydrogenase subunit A.
A and
Yeah,
then
and
B.
it's a branch chain keto acid dehydrogenase subunit B.
B.
So
Okay.
it's the name of the gene we represent in this fashion. So if they are mutated, we'll have respective MSUD subtypes like this. And this one, of course, is because of mutation of second enzyme, which is transacylase.
Okay.
Transacylase enzyme mutation. That's a gene is called DBT gene. So dihydro.
And I would also request you to,
Yeah.
add a line about, what would we do with these babies, and what is the advice
See,
that we
as
have
you
to
have
do?
understood, okay, basically there is a problem in the branch chain keto acid degradation. We have a lot of branch chain keto acid, and they are creating all sorts of trouble. And increased leucine is also competing with other amino acid for entry in the brain. So the diet plan is the current regime of treatment in such babies, and the diet should be given which should have restricted amount of leucine. It's a
Okay.
formula diet, restricted amount. We don't have to give leucine to the baby, and other amino acids should be calculated and should be given. So that's called formula diet for MSUD, and because we are restricting certain amino acids which may have gluconeogenic role. We have to supplement excess fructose and glucose, excess carbohydrate and calories we have to give to this baby because
Okay.
we are restricting the amino acids. So that's the current
And
treatment.
I also wanted you to help us, and maybe why we are calling this disease as the maple syrup urine disease.
Yeah.
So this is the maple tree that you can see, and this is the maple syrup that you see on the side, and you can see that how it looks like, and it has a
But more
very
than the
characteristic
appearance,
odor.
yeah, odor is the
So
something which is very catchy.
and
More than the appearance, we should actually talk about odor.
odor.
Why this disease is called MSUD? Because in this disease, the patient urine is having a characteristic odor which is like maple syrup. So that is why they have
And
named it
that
as,
is what is used as a condiment in the
yeah,
Latin,
in making
in the
wafers
yeah,
and other
in
things
Native
in foreign
Americans they
countries. Yeah,
use it.
they
And
use
so
it.
maybe that is the reason why we call it
That is
the
the
maple
reason why
syrup
we
urine
call it,
disease.
and it's also called as burnt sugar
Yeah.
disease because burnt sugar odor, the urine is having burnt sugar odor. So it's a maple syrup urine disease having characteristic odor. At times they say smoky sweet odor. So they all are synonym like
So
maple
do
syrup.
we actually use this order in your clinical diagnosis, or is this
Yeah,
the
it's
only
very
thing? Yes,
characteristic.
why?
And let me tell you that maple syrup odor in cerumen you'll be getting
Hmm.
very early in life, like 12
Hmm.
hours of birth.
Hmm.
You'll start having that odor in the cerumen.
Hmm.
But when you like check the baby of fourth to fifth day of this particular having this particular disorder, if you're examining the urine of that
Hmm.
baby, the this characteristic odor in the urine comes little late. It takes 4 to 5 days, but cerumen you will find very early this characteristic odor.
So
So
now
it's
may
very
I
much
ask you to, Dr. Poonam, to maybe have a quick one-liners on the disease. Maple syrup urine disease
yeah,
is autosomal,
autosomal recessive
recessive,
disorder.
and usually the child would be out of a consanguineous marriage.
Yeah,
That will be given
basically
as a
because
hint.
high
And
chances of manifestation.
presentation,
Presentation will be normal birth, but
mm,
very early
very early
deterioration.
deterioration.
3 to 4 days, the neurological deterioration will start, and baby will start becoming weak, lethargic, will have opisthotonus kind of
Like we saw in our
manifestation.
patient, like we
Yeah,
saw.
it was a classical
Yeah,
presentation.
and
Yeah.
the MRI would have the
MRI, you have
myelin-splitting edema in the
yeah,
areas
the
that you
accumulation of
see myelination at that
yeah,
time. You see
yeah,
that area to show
yeah,
edema.
yeah,
And MR spectroscopy can help us by
yeah.
accumulation
That's a
of
very good
branched chain
investigation.
amino acid and keto acids
Okay,
along
and
with
as well
the
as lactate.
lactate.
That's
That
an
is what we
unusual
saw.
finding, no?
Yeah,
Lactate and valine so much giving you a peak. It's
yeah,
not there in the normal
yeah.
baby. And I've told you the lactate white is high. It's
And
because of
then we
increased
we
NADH.
confirm it by the test like
By DNPH test, it's
DNPH.
very, I
Yeah,
mean, that's a gold standard test, I can say biochemically, but
yeah.
most of the time DNPH reagents are not there in the lab,
And
so that time they
allo isoleucine
LO
levels,
isoleucine,
yes,
yeah, it's an isomer of
and plasma
isoleucine.
level of these amino
Yeah, it's
acids.
going to raise.
And then we discussed about the diet restricted in these, especially
Diet
in the
restriction,
leucine.
like at times they say complete protein restriction, but practically that is not possible because baby has to take amino acids for development and growth. So the ideal management plan is that leucine should be restricted
Yeah.
and other amino acids should be given in a calculated amount.
So I hope you enjoyed this episode of Unplugged, where we picked up a inborn order of metabolism and we tried to discuss the radiological and biochemical part together. To the best of my information, ours is the only channel on YouTube where we try to bring up integrated medicine. So do write back to us in the comment section of this video and tell us how did you like the experience, and do let us know any other disease that you want us to create for you in future, because at DAMS we believe in integrating medicine and trying to connect those dots which you see as I'm like, as a radiologist I'm looking at one dot, as a
Yeah,
biochemist
segregated
she's
rather
looking
than
at
learning
another
it
thing, but
segregatedly. Let's
nobody is
combine.
actually learning it
Yeah.
together. So that is our attempt at this series. So I hope you enjoy this. We wish you all the best for your future endeavors, and we look forward to hearing from you. Do follow us on the DAMS Daily channel on YouTube and DAMS Daily page on Facebook for more such videos. Thank you.
Best wishes. Thank you.